Yo voy a dejar el rato.
Okay.
Vamos a empezar.
Hola a todos, muchas gracias por estar con nosotros en nuestra sesión mensual de CODET Vision Institute. Por cortesía, nuestro invitado especial, la sesión en esta ocasión será en el idioma inglés. Y el tema, como ustedes saben, es un tema muy interesante y muy prometedor, que es sobre la terapia génica en enfermedades de retina, específicamente en distrofias retinianas. Hello everyone, thank you for being with us today in our monthly session of CODET Vision Institute. Today we have the honor to have a special guest, Dr. Shyamanga Borooha from UCSD. He's going to be with us for the discussion of the cases, and he's going to give us a talk about gene retinal therapy for retinal dystrophies. It is a great honor to have you here, Shyamanga. First, I'm going to talk about his impressive CV. He is currently an assistant professor of ophthalmology at UCSD. He did his residency at Edinburgh Rotation in UK, and then he did 2 retina fellowships, one of them at Moorfields Eye Hospital, a very known and prestigious hospital, specializing in retinal dystrophies and inherited retinal diseases. He has a PhD, which he did it at the same time as he did his residency of ophthalmology, in stem cells and gene editing to model inherited macular disease. He also did a postdoctoral training at UCSD, and right now he's the head of a lab investigating novel treatments for retinal dystrophies. He's also the head of a regional center for inherited retinal degenerations in San Diego. So our session is going to be first for the discussion of 2 cases. We have our retina fellows that are going to present the cases. And after that, Dr. Shyamanga is going to have a talk about gene retinal therapy. Thank you very much for everyone for being here. And thank you very much, Shyamanga, for being with us today.
Thank you.
Hello, I'm Dr. Ríos, Retina Fellow of CODET Vision Institute. I'm going to present the following clinical case. It's about a 56-year-old Hispanic male patient without relevant personal and family medical history. Patient presented with decreased visual acuity in both eyes starting 10 years ago. At the first visit, we found best corrected visual acuity 2150 for the right eye and 2050 for the left eye. The anterior segment presented nuclear and posterior cataract in both eyes. In the multicolor image, we can see bond spicle 360 degree, attenuated bezel, and optic disc pallor. In this slide, we can observe a fluorescein angiography with perivascular hypofluorescent zone corresponding to a window defect due to RPE atrophy. In the 10-degree visual field, we found a remaining central island in both eyes. So we decided to perform an OCT that show the presence of cystomacular edema with larger increase in macular central thickness in the right eye. Finally, with all the data collected and clinical study performed toward patients, a diagnosis of retinitis pigmentosa with cystomacular edema was made. The patient was treated with topical dorzolamide without success, so we decided to start treatment with intravitreal injection of ranibizumab in both eyes. Obtaining a partial response with a single dose, therefore we applied a second one, and the final visual acuity achieved was 2100 for the right eye and 2040 for the left eye. In conclusion, cystomacular edema can significantly reduce visual acuity in retinitis pigmentosa patients. The prevalence of cystomacular edema has been reported between 11 to 70%. A number of treatments for cystomacular edema in retinitis pigmentosa have been attempted, including vitrectomy, laser grid photocoagulation, systemic or intravitreal steroid, oral topical CAI continue to be the first-line treatment. Anti-VEGF intravitreal injection could be an option for cystomacular edema treatment. Osgood reported significant resolution of cystomacular edema at 6 months after single ranibizumab injection. Genetic diagnosis is mandatory when considering gene therapy treatment. Currently, there exist more than 50 different genes for the diagnosis of retinitis pigmentosa. Thank you.
Okay, thank you very much, Dr. Ríos, for presenting your case. So we wanted to present this case because this is a case where we can offer the patient some improvement in vision, not by treating, of course, the baseline disease, like in this case it's retinitis pigmentaria, but in this case we can treat the macular edema associated with this condition. What do you think, Dr. Borooha, about treating the patients with retinitis pigmentosa with anti-VEGF agents, or do you use another strategy to treat them?
Yeah, so thank you, Dr. Ríos, and thank you, Dr. Groman. So looking at retinitis pigmentosa, first of all, let's maybe come back to what causes this kind of fluid. It's still not known. There's a thought that this is caused by Muller cells gradually degenerating, and Muller cells take fluid out from the retina. So, and then the next question is this inflammatory? Well, there is some inflammation sometimes in retinitis pigmentosa, but that's not a major response. So it's still unclear what the cause is. What is clear is not a clear VEGF response. It's not like macular degeneration. It's not like diabetes or diabetic retinopathy. However, there have now been a couple of trials, and you quoted one there, that have started to find evidence of improvements with anti-VEGF. So I would do exactly what you've done. So first of all, try dorzolamide. And actually sometimes, for some reason, there's a difference between dorzolamide and brinzolamide. So actually I'd try brinzolamide, which is also better tolerated as well. If that doesn't work, then I'd discuss the options. There can be something as simple as a steroid injection just for a trial, but with that comes side effects, including cataract and high pressure, like we had a patient today. And then anti-VEGF would definitely be further down the line. But but again, anti-VEGF has different levels of success. But I'm glad to see that you had great success with this patient.
Yeah, thank you. Yeah, in this case we have success, but of course, as you said, there are so many cases that we don't have any improvement, even in vision or even with in the OCT or in the macular thickness.
Yeah, and I think the main thing to understand is that this eventually burns out. This is most commonly seen in dominant disease, which is a sort of slower disease. So it will burn out, and like diabetic retinopathy or macular edema, the outer part of the retina is usually maintained. But obviously, you're trying to stop the disability of central vision as well as peripheral vision in these patients, which is why you're treating them now.
Correct. Okay, perfect. And do you have any preference for any kind of anti-VEGF agent, ranibizumab or bevacizumab or even aflibercept?
Yeah, I think probably aflibercept actually first, just because of the theoretical duration of time, and the question is something that sort of stays in the eye a bit longer. This is an intra-retinal sort of problem rather than a choroidal problem. So something like aflibercept is supposed to last longer, but ranibizumab is the one that's been tried the most, really, because it's the first that's come along, and the best data is for that.
Okay. Okay, perfect. Any other questions from the audience? Okay, perfect. We're gonna pass to the next case. That is gonna be presented by our other fellow, that is Dr. Leslie Niebla. She's gonna present us another interesting case, so we can discuss it after the presentation.
Hola, buenas tardes. Voy a presentar entonces el siguiente caso. Good evening. I'm going to present the next case report. Okay, it's a 65-year-old Hispanic male with a familiar history of brother with poor vision with unknown disease. His main complaint was the loss of central vision starting 10 years ago. At the ophthalmology of the exploration, his best corrected visual acuity with a Snellen chart was 20/25 in both eyes. And an anterior segment without alterations. We saw in the indirect ophthalmoscopy, and we visualized in both eyes, as represented in these multicolor images, that on the macular area is the presence of a beaten bronze appearance. So also there's some white flecks, which the white arrows show, white flecks that is in the macular area, and they extend towards the perivascular area. Also, some of them reach the mid-periphery. It also, we can see the sparing in the perivascular and peripapillary area. So we also have some regions of atrophy, which are inside the blood circles in both eyes, which is of bigger size on the left eye. Okay. So in this image, it represents blue autofluorescence. We can see that in the macular area, there is some hypoautofluorescence in the right eye and on the left eye, which corresponds to the zones of atrophy that we saw on the multicolor images. We can see also that there are some hyperautofluorescence, which correspond to the flecks that we saw also, but they also have some hypoautofluorescence that we see with the blue arrows. And with this modality, we can see that peripapillary sparing more evident. Okay, on the fluorescence angiography, we found the presence of a hyperfluorescence, and since the early arteriovenous phases that persist till late phases, which correspond to the flecks that we saw on the multicolor images. We see also that on the macular area, the presence of transmission that we saw over here and over here, that corresponds because of the pigment epithelial defect. And also it corresponds with the areas of atrophy that we saw. On the OCT, we can see that there is on the thickness map that there is so generalized thinning of the macular region, more evident on the central area. We can see that there is a little alteration in the morphology with attenuated foveal depression. And we can see that the outer layers are absent. Here, the red arrow help us to mark the zones where is the outer layers we can see that are continuous, and then they stop to, we don't see the ellipsoid band or the external limiting membrane in both eyes. Okay, so we conclude that our most probable diagnosis represents an ABCA4 associated disease, which is Stargardt dystrophy. And we have to make a differential diagnosis with other diseases like multifocal pattern dystrophy, which is a Stargardt-like disease. Also, we have with central areolar choroidal dystrophy, just because of the central atrophy we see in the macular area. Also, age-related macular disease because of the age of our patient, and retinosis pigmentosa, inversus or albescens type, equally because we saw the white yellow flecks on the posterior pole. So our plan was a genetic and molecular assessment, so we can make that definitive diagnosis and make a follow-up to the patient. The conclusion is that we know that mutation in ABCA4 is a known causal of autosomal recessive Stargardt disease. Like our patient, we suspect this in our patient, even though it's a late presentation. So we have that there are other phenotypes associated with mutation in this gene, so the importance of the genetic assessment. We know that the electroretinogram is an important tool for the prognosis of the patient, and we are in expectation of treatment, searching for vectors, well, in case of gene therapy, searching for vectors with large cargo capacity that will be able to transduce through photoreceptors efficiently. So there are some investigational therapies. I saw these three, which is the ALK001, which is an oral substitute of a deuterated vitamin A, and which will reduce the accumulation of the cytotoxic A2E and lipofuscin. Is in phase 2 right now. The other one is the STAR gen, that is a subretinal injection of a lentivirus vector. We will make a gene transfer and halt the disease. And the other one is a stem cell transplantation of human embryonic stem cells, and that will help to differentiate into a variety of cell types, and is also on phase 1 and 2. So there's like hope. So thank you.
Thank you very much, Leslie, for presenting your case. So we wanted to bring this case to emphasize the importance that there is right now at this moment to do genetic testing for all the retinal diseases, because as you already know, we already have some clinical trials that are giving us very promising results. And right now we cannot only stay with the clinical diagnosis, we have to do a genetic testing diagnosis so we can offer the patients at some time in the future, hopefully short-term future, some treatment. What do you think, Shyamanga, about this case, and what would you do, for example, for these patients? Would you add any other studies and, of course, genetic testing?
Yeah, so thank you again, Dr. Niebla. It's a beautiful case and a very nice presentation of what looks like a classical Stargardt type picture. So I think before we again go forward, we have to sort of go backwards a bit. So one of the things that you'd like to know about this patient is a late presentation. It's unusual. Stargardt normally presents from the age of 5 to usually the early teens, 20s latest. So this is a patient who's in the 50s. They can be late presentations. But the other thing is the family history. So in this case, Stargardt is generally a recessive disease. So you need 2 mutations which have to be abnormal. So it's very important to make sure you exclude a dominant family history. because that could lead to other things. And one of the things you mentioned there was pattern dystrophy. So recently we've been caught out by a patient who was in their 40s who looked like they had Stargardt. And then we did the testing and it turned out to be PRPH2, so RDS peripherin gene, part of the pattern dystrophy. And when we looked back and asked about family history, so it was done backwards, eventually we found that actually there's a dominant sort of but variable disease in the family. So that's the first thing, and then that helps you with a genetic diagnosis. And with the genetic diagnosis, that's important because when you come for clinical trials, some of these are gene dependent. So the second thing that I'd like to do here, if it is Stargardt, is to do an ERG, as you alluded to, as Dr. Niebla alluded to. And the reason is because there's different kinds of Stargardt, some that affect the central area, some that affect the rods as well. And so the different types can be worked out by ERG. Obviously, the ones that are further peripheral can be worse. And they don't necessarily follow the imaging. It follows the electrodiagnostics, which is why it's so important.
Great, perfect. Yeah, that's one of the things that we are hoping to have here very soon, to have an ERG equipment to do all the ERGs to all of our patients. And of course, in the genetic testing. As you already said, for example, in cases where you don't know really what is the specific diagnosis of a patient, the genetics testing will tell you like the name and the last name of the disease.
Yeah, and I know that we've been talking a lot, and you're trying to set this up. So I think for the genetics clinic, really, you need to have these different steps, and I'll probably highlight that in my talk as well. But it's interesting to see the different kinds of potential treatments that are coming on. So these are trials again, and there's lots of different types. And really, as Dr. Niebla said, the gene is very big in this case, which makes it difficult to treat. So it's probably the most common juvenile cause of dystrophy. And so it's really something that people want to try to treat, but they can't fit it in the normal AAV or vectors. And I'll again talk about that a bit later on. So they're trying all these different ways of trying to treat it.
Correct, that's great. Yeah, exactly. I think this is a great era for retinal dystrophies. We already have, as you know, treatments available in the US, FDA-approved treatments for certain types of dystrophies. So I think this is another reason why it is a great time to be a retina specialist. So without further ado, if you don't have any other questions, we can start with your talk.
There's some, sorry, Sergio, were there some questions? I'm not sure in the chat area. I don't know if there's...
Okay, let me... No? I think we don't have any...
We don't, okay, that's fine. No problem. Okay, so I'll just start my talk, just 1 second.
Perfect.
Okay, can you see the screen? Can you see that, Sergio? Yeah, okay.
Yes.
Okay, perfect. So I'll just start off. First of all, thank you very much, Sergio and the CODET Institute for inviting me to talk. We've been trying to set up this collaboration. We're so close across the border, so I'm so pleased that you've reached out to help set this up, and hopefully we can together sort of help improve the genetic diagnosis and management of these patients in our retina clinics. In terms of my talk, I really wanted to talk about the revolution, and it's not really this revolution. So hopefully you can see my arrow, but it's not the French Revolution or any other revolution that we're thinking of, but really a revolution in genetics. And that's in two things. One is the testing, which we just talked about, and also the other thing is the treatment, which is gene therapy, and that'll be the bulk of my talk. So let's talk briefly about genetics. And this is something that everyone did at medical school, but I just want to briefly go through this. So there's two main types of inheritance. So that's autosomal, and even in this is broken into dominant and recessive. And dominant is really where abnormal protein is formed and causes damage to the remaining protein, and recessive is where there's a lack of a protein. So recessive skips generations, and dominant, you follow a family tree. Then you also have X-linked disease, mainly X-linked recessive, and that mainly affects boys and mothers are carriers. But these are the most common forms of inheritance. So what's happened with testing? Well, testing has previously been looking at these different families to try and find the genetics. That was the first stage in the 80s and 90s. Then we moved on to targeted. So we used PCRs, polymerase chain reaction, just to look at certain mutations in different genes. So that limits everything because you only look at the known mutations. Recently, however, this has become much more accessible, and it's something that we're using in clinic here, whole exome sequencing. So this looks at the coding areas of the genes, but misses the introns, which are like the dark matter. So this picks up approximately 60% of mutations, 67% of mutations. But we're still missing a few mutations. And now gradually becoming accessible with companies such as Illumina, which is just based in San Diego, which do the sequencing plus the analysis. You can look at the whole gene. So the whole genome, which is looking at the exons and the introns. And this should theoretically pick up even more, probably getting up to 80 to 90% of mutations, although that hasn't been fully proven yet. So essentially, we are really changing the way the clinic works now in terms of diagnosis. So you can get a turnaround in as quickly as 10 days just to find one mutation amongst the whole genome. So this is just a brief diagram, just looking at some of the genes causing retinitis pigmentosa. But now actually, there's over 300 known genes. I think the last count, roughly about 320 known genes, including mitochondrial genes, which cause retinal dystrophy. So we're really increasing the number of genes that we're identifying and mutations. But how do we treat disease? Well, I'm going to talk today about gene therapy. So I'll just show you the areas that we look at. The important thing is to understand that these diseases generally go through a preclinical phase or early phase where there's very little or no symptoms. Then they have a clinical phase, which have a degenerative start and some symptoms. And then a very late stage in which the cells are lost. So in these cases, you need different treatments for different stages. So today, my talk is really going to be looking at gene therapy. And gene therapy really covers the first stages and early stages where the cells are still there. But I'll also show you another kind of gene therapy called optogenetics, which is a new technique looking at the cells that remain. So what is gene therapy? Well, if we take the DNA here, there's a mutation, and this can either cause a complete loss of the protein, so no protein, such as in recessive disease, or it can cause an abnormal protein, which causes disease, such as dominant diseases. And what does gene therapy do? Well, basically it uses a vector or carrier to take these gene products of different kinds, which I'll go through, and these are transported either into the jelly of the eye, the vitreous, or subretinally to try and get to the right cells and act as a depot. Those viruses then go into the cells and then produce these proteins, which in the end cause allow the treatment. Now, this has not been easy. So this has started in the 1990s when they first started trying these treatments. People like Robin Ali and Jean Bennett in Pennsylvania. So the trouble is, first of all, you're putting a virus, and we all know the problems with the viruses now. So I would have thought that this was going to cause the main news this year, but unfortunately a different virus is causing the news this year. The other trouble is that when you're doing this subretinal injection, it's only going to one area of the retina. And actually there's retinal disease all the way across the retina in many cases. The other trouble is that the viruses can only hold a certain amount of protein. And finally, these viruses can cause an immune reaction, which can sometimes be severe in the eye. So how do we choose these viruses? Well, we already heard about one virus today, but the prototypical, the first virus that we used was adenovirus, which is the virus that we have in conjunctivitis and causes sore throats. Now, this is very highly infectious, and as a result is good for infecting the cells. And it has large carrying capacity. However, it causes a massive immune reaction. And that's why we've moved gradually to adeno-associated virus, which has a very low immune reaction. The only trouble with this is that it can only carry relatively small genes, and that limits its use. And that's why some of these studies, such as the one that was mentioned by Dr. Niebla early on, use lentivirus. But this is thought to be much more dangerous or more risky, because this lentivirus integrates into the genome. It's a retrovirus, similar to HIV. So this is the main area of the talk that I'm going to talk about today, but there is also lentiviral treatments, but they're very early phases at the moment. So I talk about gene therapy, and then you guys have probably not seen too much of this in the clinic, but does it actually work? Well, the first gene therapy that was approved by the FDA, as Dr. Grohmann said, was Luxturna. It's called, I've got a very long name called Voretigene neparvovec, but I'll call it Luxturna. This is treated by giving a subretinal injection with a virus that goes into different cells, especially the RPE cells. There, the virus expands and produces its genetic product, which is RPE65. So this is a good disease because the structure of the retina is actually pretty good, but actually there's just a dysfunction. So theoretically, if the protein was to be replaced, the function would return. But does it work? So this is an example of a maze they created for the FDA to show that it was functional. On the left-hand side is somebody who has not had treatment. And on the right-hand side, under the same conditions as the same person after treatment. So see what you think. So I think you can clearly see a difference that there has been a functional element. But these trials are slightly different from the AMD trials or the diabetes trials that we've seen previously. So Luxturna has noticed a difference in the maze or visual mobility test and in stimulus testing, where a light is placed and a person presses a button when they can start seeing a light. However, it did not show very much improvement in visual acuity, which is tested with a Snellen chart. And this suggests that really we need slightly different endpoints for gene diseases. And these include things like functional studies and potentially threshold studies. And the other thing is things like microperimetry, which I'll show you later on. So gene therapy studies are slightly different from other trials. So the findings of this trial show that there was an improvement, but why is this important for you? Well, this is the first approved trial in America and also now in Europe. And the plan is actually to extend this now to Mexico and Latin America. So you may be seeing patients with these conditions that you may potentially have to put forward for trials. And that should hopefully come in the next 1 to 2 years. But have these technologies, so gene therapy and gene editing and genetic diagnosis, changed our clinic? Well, I think just to help you, I'm just going to run a mini retinal clinic just now and go through some cases. I'll go through them very briefly, so not as much detail as the fellows, but then I'll just show you exactly where we're going with the different kind of potential trials. So let's see case 1. So the first case is a 30-year-old male. He had gradual onset of blurred vision in both eyes. This really started in the last 7 years and is gradually getting worse, with only mild nyctalopia. The family history has 1 brother and 2 maternal uncles who are affected, suggesting an X-linked pattern. The visual acuity at the center is 20/50 bilaterally, and the patient is markedly myopic. So let's see the retina. This is an Optos pseudocolor image and showing quite marked marked peri-papillary changes, really due to the myopia, I think, mainly. So it's not very clear, and the same both sides. So not really clear in terms of bone spicule abnormalities. But the autofluorescence is really helpful in these cases. And you can see that there's an area of loss just here in the retina. And this goes along with field defects. So X-linked RP, what's the cause? Well, the most common causes for X-linked retinitis pigmentosa is RPGR by far. There are also mutations in RP2 and also less commonly in other mutations. So what we did with this patient is whole exome sequencing. So where we looked at the exons. And eventually a pathogenic mutation was found in a gene called RPGR, as we mentioned earlier. So in this case, the retinitis pigmentosa, or the atypical changes here, are caused by X-linked RP and retinitis pigmentosa, or RPGR. So are there any treatment trials or options? Well, this paper came out quite recently, looking at the phase 2 trial results from the Night Star trial. This came out earlier on this year. So this looked at 18 patients with a 6-month follow-up, and was mainly a safety trial, but also had outcome measures looking at vision, microperimetry, and central retinal thickness. And microperimetry is another thing that we sort of do in clinic nowadays quite regularly. So here's one of the things that we looked at. So the vision didn't change all that much, but here we're looking at the treated eyes. So one eye was treated, one eye untreated. And you can see that in these cases, the treatment started at baseline here, and the area that can see is in red and gradually increasing. And this is probably the one that has the most from baseline, as biggest change, and the untreated eye is relatively similar. So this showed clear microperimetry changes and significant changes. And so now the phase 3 trial is about to be started in this. So the treatment was thought to be well tolerated and safe, except for some subretinal inflammation, which is treated with oral prednisone. The similar findings very recently published last month, in fact, by Mira GTX, which is another company doing phase 3 trials. And that's one of the trials that we're going to be starting just here. So case 2. So case 2 is a 53-year-old male patient and complaining of poor peripheral vision. The patient also has nyctalopia and glare, and was diagnosed at the age of 38 and has a visual acuity of 20/25 bilaterally in the central area. So again, these are optical pseudocolor images with a slight opacity here as well, posterior subcapsular lens opacity, which is blurring some of the central area. But you can see again classical signs of RP here. So with bone spicule pigmentation, some atrophy, and also vessel attenuation. And this is seen bilaterally. So we did genetic testing in this patient. This patient had no other syndromic signs, but was noted to have mutations in USH2A. This is probably one of the most common causes of retinitis pigmentosa in adults. So this is just a genetic report, and this shows the mutation and what effect it has on the protein. So this causes a premature stop, which is very likely to cause abnormalities. And this is likely to be pathogenic as well with the change. It hasn't explained exactly why, but it will cause degradation. This is also thought to be pathogenic. So in this case, this is a recessive disease with two pathogenic mutations. Ideally, what you want to do is to make sure that this is not on the same allele by testing parents. This is called a segregation analysis. So are there therapeutic options or trials? So this patient didn't have macular edema, so we're thinking about the next stage. So this patient has mutations in exon 13. So now I'll talk about RNA therapies. RNA therapies use RNA, but by their name, and either act as a band-aid or elastoplast over areas which have mutations or abnormalities, and then stop the DNA binding machinery binding. Or they're editing types which edit or block the RNA itself and then stop the effect of the mutation. So in this case, the mutations are in exon 13, both of them. So you can see here that normally the pre-mRNA from the DNA would be moved onto an mRNA with exon 13. Exon 13 abnormalities would cause degradation of the mRNA, nonsense-mediated decay. However, what was been shown in the animal models is that if you block the exon 13 by covering up the splice site, the area between the intron and the exon, then you can form exon 12 and 14 without 13. And this still forms a functional protein, which isn't decayed. So the thought is, if you carry on and block exon 13 where these two mutations are, you'll still have a functioning protein. And in H2A, all you need is a small amount of functioning protein to be able to have retinal function. So this is called an antisense oligo. And these kind of things are not new. They're also being used for other areas, such as macular degeneration. So you'll soon be seeing these trials in other complement abnormalities as well. So the main trials that are doing this at the moment are one for Leber congenital amaurosis for certain mutations, which are active in recruiting, and one for H2A. And so we're going to put this patient forward probably for H2A treatment once I speak to him again. So moving on to case 3. So case 3 is a 70-year-old male who had normal vision to the age of 40, then first lost central vision, and then lost peripheral vision later on. So far we've really been looking at retinitis pigmentosa cases. This is the patient that's 70 years old, and this could be anything because this is very late stage disease. But the history goes slightly different from retinitis pigmentosa. So here there's marked atrophy, but there's still some remnant of retina. Unusually about this patient, if you look to the front of the eye, there's some changes. I don't know if you can see these, but there's some very long zonules coming in. Looking more closely, you can probably see them just here. They look like fine hairs or eyelashes. So this is very strange. It's a posterior disease with anterior changes as well. And the cause of this is C1q TNF5 abnormality. So this is a dominant disease, and this causes dominant macular degeneration. So it can be confused with macular degeneration in the 40s and 50s, because it starts centrally, and this moves peripherally to the whole retina. The main pathology is a thick deposit underneath the retina, and this causes the loss of the retina above it. So I've actually got some postmortem specimens I prepared myself for this patient, not from this patient, but another patient in the family. And here you can see the neuroretina here, the eosin stain. Underneath you can see this deposit, which is Brooks membrane thickening. And underneath that is the choroid, which is slightly pigmented here. But what's of note, apart from these microglial stains which you've done, is that really what happens is the deposit eventually joins in with the inner nuclear layer. And that, once the photoreceptors have gone, but the bipolar cells still remain, although there's quite a lot of artifact here. And so in a lot of these diseases, what happens is that you lose the photoreceptors, which is just here, but the bipolar cells and the retinal ganglion cells remain. So if there was a way to target these cells here, this would really allow us to continue to allow some kind of vision. So it may not be good quality, but at least there'll be some light and perception. So this is really where optogenetics come along. What optogenetics does is it uses intravenous injection, places a virus in, and the virus targets the inner cells of the retina rather than the outer cells, which are dying. And here it puts in a pigment similar to an opsin, which identifies light and then does a transduction and causes an activation of these cells. Then electrical signal is passed along and goes onto the optic nerve. And as a result, the patient can get perception. And this seems to have worked relatively well in mouse models. And now they're trying in early phase 1 studies in human patients. So these are just starting 2 or 3 places around the world, including one in France and one recently from a company in New York. So we talked about these different things, and I'm very excited about the last one as well. So this is the final case, and hopefully we are of interest. So this is of a 50-year-old female, and this female patient has had low vision since birth. She also demonstrates the ocular digital phenomenon, has keratoconus because of this, and doesn't feel like she's had any kind of vision or any change in vision since birth. At the moment, she can just about see hand motion bilaterally. So the images are very difficult to get because of marked nystagmus, but the Optos images basically show a retinocyte pigmentosa type picture. So an RP picture from birth, this is suggestive of a labor congenital amaurosis of some kind. So labor congenital amaurosis is a wide clinical diagnosis, but with many causes in terms of genetics, with more than 25 different genes. Amongst the most common of these is a gene called CEP290, and we've already heard about RP65, which is what Luxturna treats. These diseases, again, are thought to be good to treat because the structure of the retina remains very good. And again, it's trying to treat the dysfunction of the outer retina. So we did genetic testing in this patient and identified 2 variants in CEP290, which is one of the major causes for labor congenital amaurosis. We sometimes get this diagnosis. So one is thought to be pathogenic from these computer simulations or from previous data, and one is likely to be pathogenic because there's no previous data, but this shows an early stop of the protein. So it's suggestive that this would give a protein that would be decayed early, or the RNA would be decayed early. So this is most certainly LCA10 due to CEP290 mutations. And what's very interesting is that this mutation here, 2991, is one which is being targeted by a number of different companies. What this causes, so this is from one of the British Journal of Ophthalmology papers, but in this disease, it looks at CEP290, and there's 2 exons. These are the coding areas. This is the intron, which is the dark matter in between. But it creates a new exon just here, the mutation. So if we could somehow knock this out, then the gene would go back to producing exon 26 and 27 again. So how can this be done? Well, in recent sort of papers, especially one from Nature Medicine, where they looked at models for this, for labor congenital amaurosis, they use a CRISPR system. So CRISPR, people have probably heard about now, but is a gene editing tool. It's made from RNA generated by different bacteria. They use the RNA to target viruses initially, but we're now using this to target DNA. So by targeting different areas with a special sequence, which is just shown here, we can generate a cut. When you generate a cut, you can essentially knock out that mutation. And then that would allow the gene to work again properly. So this is a bit complex, but essentially what we're trying to do is to try and get rid of that mutation by targeting the whole genome. And this is run by a company called Editas and Allergan here in the US. And this is the first trial for CRISPR in any kind of medicine. So this looks to, it's a phase 1 trial, looking at AAV and Cas9. And basically it's given by a subretinal injection, again in a virus package. And then these components are released. They're released into the retina, and these retinal cells and the photoreceptors thought to be changed by this. And it worked very well in the mouse model. And I'm glad to say that, so we've started participating in this trial with one of the first patients. So we're just hoping that this is successful, because this technique can potentially be used to target other mutations and correct a range of different diseases. So hopefully these results will come out in the next 2 years, where we look at the long-term data. So really, I brought you on from how we've tested before and how we just observed patients to the latest kind of treatments. So as I said already, there's one approved drug, Luxturna. There are multiple of these approaches in phase 3. So there's things like achromatopsia, choroideremia, RPGR, which I've not talked about, and another RP65 trial, which is in phase 3 as well. And there's also about 30 or 40 other diseases which are in phase 1 to 2. So this is very hopeful for later on. So this has really changed our clinic approach as well, because before we used to observe patients, but now the role of the retinal physician is to try and decide which trial or which treatment is best for these patients in a small but increasing minority of patients. So what's going to happen in the future? Well, the future is looking bright for a number of the common diseases. Obviously, these treatments won't work for everyone, and that's why they're looking for other interventions which can cross across different diseases, such as optogenetics. And I haven't talked about stem cell therapies or retinal prosthesis in this talk. And over the next 5 years, so what's the aim? The aim is really to get a better virus. The next thing is to get a virus that doesn't cause an immune response, and one virus that treats the whole retina. And then if we select the right patients, then hopefully we should be able to get the right treatments and at the right time. And if we do it early enough, we should hopefully get better results. So that's the aim. So we'll see what happens over the next 5 years, but definitely the last couple of years have rapidly changed the way that we're dealing with clinic. That brings the end of my talk, and I thank you for listening, and if there's any questions, I'm more than happy to answer.
Thank you very much for your talk. It was very impressive and amazing. And I think it's a really great era to be a retina specialist, as I already said, because we now can give some hope to the patients that before we used to tell them that there's nothing that we can do at that moment. And as already you saw with the talk from Dr. Borooha, there are so many options that are in research and hopefully will be available even in Mexico as Luxturna or other kind of the techniques that we can offer to our patients. So we do have some questions from the audience. Let me see. Okay, so there's one question from Dr. Avila. She's asking if Luxturna injection is guided by an OCT.
Yes, so what I didn't talk about today was the science behind the surgery. So I talked about the science behind the development of the vector, but really these things have really developed. So ideally, these Luxturna injections are ideally done at centers that have this OCT, intraoperative OCT. And how that's done is you're trying to create a bleb of a certain size. So not too big so the retina gets affected, and not too little so that you don't get enough. And also that there's not reflux. So this allows the bleb to be made, and then inside inserted the virus. So at the moment, what they're trying to do here is really to keep it to those centers. So that makes it a bit more difficult, but we'll see. I think as techniques change, things may change, because now people are beginning to do multiple injections at the same time. That may negate the need for some of these kind of equipments. Yeah.
Perfect. How many doses of Luxturna are required for a complete treatment per eye?
Yeah, so at the moment, as I said, it's a single treatment. But that's interesting. So the thought is that it lasts a long time, and definitely in animal models and in the early human patients, it has lasted a long time in terms of the treatment. But this is important because initially this is this one injection. But as I mentioned, there may be other areas of the retina which need treatment. There's not much leakage outside the bleb area. So maybe now what they're going to try and do is go back and retreat these patients. But at the moment, it's just a single treatment.
You know the cost in the US for these kind of treatments, and are they covered by any insurance or any foundation?
Yeah, so unfortunately the foundations can't really afford this, but they are expensive. so the reason why drug companies are really targeting these diseases at the moment is because they're called orphan diseases. So orphan diseases have a special denomination in America and in Europe as well, which means that companies can potentially charge higher, and they can bypass certain testing loopholes. So the testing is much faster for these diseases because there's no treatment. So the cost is very high. So when I think it first came out, it was in the order of 600, 700,000, if I remember, for the treatment. But it's gradually coming down. And I think places like the NHS, for instance, the National Health Service in the UK, I think now got it down to about 200 to 300,000, I think. So it's much lower, but it's still a lot. The insurance companies, yes, the insurance companies are beginning to pay for these injections, because if there's treatment with some insurance plans, they should really be covered. So at the moment, they're covering that. But we'll see, because if the burden of this increases, it may change. But I anticipate that the prices will start coming down as well. And this competition is actually a good thing, because again, they will affect the price, as you know.
Yeah, sure. Okay, let me see. Another question. Okay, there's a question from Dr. Arturo Chayet. What do you think of quantitative funds autofluorescence imaging for all these genetic retina diseases? Like to use the autofluorescence to measure the progression.
Yes, so autofluorescence has been used as one of the main measures. There is some difficulty, especially in RP disease. So in the disease that I showed earlier called late onset retinal degeneration, it's easier. It's a bit more like a geographic atrophy, so you can actually measure the areas. And in fact, we just sent a paper in looking at that.
Yeah.
With RP, it's a bit more difficult. But what they use autofluorescence for is there's this ring that you get, and that's much more visible than autofluorescence. And they're looking at the ring sizes in diseases such as RPGR to try and measure. So that's quantitative, and I think there's a group by Michaelidis, which has looked at that, and Jacobson's group as well in Philadelphia. So that, yeah, definitely, that's one of the things that's being used. But it doesn't give functional, which is what the FDA wants. Yeah.
Okay, perfect. There's another question here, very interesting, from Genaro. Is there any gene treatment if the affected gene is not found, if you do the testings and you don't find any mutations? So
as I said, I don't think every disease can be treated, because, for instance, today I found one in RMP200, which is a very rare disease, a rare gene. So really what we're looking for is transgene, or sort of gene-independent treatments. And one of those treatments could be the optogenetics I showed, because that doesn't depend on the gene. And then the other thing is cell replacement. So Kapil Bharti, who's in NIH, just did an interesting paper last year looking at a transplantation in pigs where he transplanted choroid, Brooks, RP, and photoreceptor, and was able to restore vision. And it's really hoped that this will be moved on to certain times of RP before there's complete loss of the bipolar and other cells above, because we know that those maintain. So I think those are the kind of treatments, but without gene therapy, then there's relatively fewer treatments at the moment. There are some stem cell treatments as well, but I won't go into that too much today, that they're trying, which are giving supportive treatment to give cytokines to the retina. So they're already being tried at the moment.
Great. The cost of Luxturna, we already said. Great. Okay. Okay, there's another question. Great presentation. Thank you. What is the cost of the CRISPR treatment approximately for the CRISPR treatment?
Yeah, so that is not a treatment at the moment. It's a treatment trial. So it's a very early trial. Okay, so that's one of the ones that we're doing here. That's at phase 1/2. So basically, I can't give a price at the moment, but that's run by a company called Editas, and the one of the scientific people, founders on there, is the guy who designed CRISPR, helped design CRISPR in the first place. So I can imagine the price will be quite high when it comes out first. But again, the hope is that it comes down as other diseases looked up.
Perfect. Okay, I think we don't have any more questions. So I think it was a great presentation. Thank you very much, Shyamanga. And well, we wanted to bring this presentation to our session because we have to be very updated, all ophthalmologists and retina specialists in this area, because as you can see, there are a lot of progression, and we can now offer or may offer the patients some treatments, or at least have them the right diagnosis and have the mutation detected. And in case that there's any clinical trial, we can try to enroll them or refer them to another clinic, like in your case at UCSD, that is participating in a lot of clinical trials. So I think it's great, it's exciting to offer these patients some hope.
Yeah, and I agree. And again, thanks for inviting me to do this all. But yeah, I just want to reiterate that now things are very much moving. So the key at the beginning is really to get that genetic diagnosis if we can, because gone are the days when we have these specialists who look at the back of the eye and say, this is the diagnosis. The genetics are the key. And so that's the first stage. And then we can talk about the other things. But those things are gradually coming to everywhere. And with Luxturna, if that comes to Mexico, then you're going to be doing gene testing, definitely.
Exactly. Yeah, exactly. Thank you for emphasizing that. I think that's what we have to do first. And if we see a patient that has any kind of retinal dystrophy, we should look for doing a gene diagnosis. So that's the first step. And after that, we can look for any treatment. But yeah, thank you. That's the main step to start. Well, thank you very much for everyone for being here. Muchas gracias a todos por acompañarnos a la sesión general de CODET. Espero que haya sido de su interés y pues estamos aquí para tratar a cualquier paciente que nos quieran comentar. Thank you very much, Shyamanga, for your great presentation. And we are very excited to have this alliance and collaboration with UCSD and with you in your clinic, to reference of patients and to diagnose our patients. And we look forward to start working with you very, very soon.
Yeah, wonderful. Thanks for sharing the meeting and inviting me. And we'll be in touch again. I'm glad that your clinic has started already.
Thank you. Thank you very much. Good night. Have a good night. Muchas gracias a todos. Muy buenas noches y estamos en contacto.